Good evening and welcome to the British Neuro-Oncology Society 2022 Patient and Carer Edition. My name is Andrew Broadbelt. I'm a consultant neurosurgeon at the Walton Centre in Liverpool and the Honorary Treasurer of BNOS. The BNOS annual scientific meeting was held in June in Liverpool this year. It was the first meeting since COVID and it was excellent to see people in person again. We had a lot of really interesting scientific and clinical presentations on all aspects related to patients with brain tumours. It was set over 3 days, sometimes with 3 parallel sessions going on at any one time. To try and help stop people's brains exploding from the excitement, we had a haunted walking tour, a talk and rap by John Barnes, the famous footballer, and a fun run in which Professor Jenkinson, who's on the panel this evening, could only make it as runner-up in the 5-kilometre race to a younger neurosurgeon from Edinburgh. During or shortly after the conference, Liz, one of our BNOS administrators, suggested doing a highlight session for patients and carers. We spoke to the patient charities who were very enthusiastic, and tonight's event was conceived and produced. I would particularly like to thank the Brain Tumour Charity, Jen and Catherine, for helping with the organisation of tonight's event, Brains Trust and the IBTA for their input, and the Yorkshire Brain Tumour Charity and Brain Tumour Research for advertising the event. We are lucky to have an eminent group on the panel and speaking, and I'd like to thank them for their involvement and work towards this. A little bit of housekeeping. Please keep your microphones switched off. You're welcome to leave your cameras on or off as you feel comfortable. The format tonight is a 10-minute presentation followed by a 15-minute session of a panel discussion and questions. We'll then move on to the next topic and presentation followed by questions and discussion. We'll not be able to answer all the questions, but we'll try and answer as many as possible. Please put your questions in the chat. Some questions may be answered in the chat, so keep an eye on that as we go along. The event is being recorded and will be available afterwards. I'd like to get the panel to briefly introduce themselves before we start with our first presentation. So, Paul.
I'm Paul Grundy. I'm the president of the British Neuro-Oncology Society, and by background, I'm a consultant neuro-oncology surgeon and chief medical officer at University Hospital Southampton.
Thank you. Helen.
Hello everybody, thank you for inviting me here. So I'm Helen Bulbeck, Director of Policy and Services for Brains Trust, the brain cancer people. I'm a cancer survivor and also a carer to my daughter who's had a brain tumour.
Thank you. Kaj?
Good evening everyone, my name is Kaj Mystery. I'm a young ambassador at the Brain Tumour Charity and I'm here to provide a lived perspective as my dad passed away from a grade 4 glioblastoma in July 2020.
Thank you. Louise?
Hi, good evening. I'm Louise Dolly, a neuro-oncology consultant at Queen's in Romford.
Thank you. Jill?
Hi, good evening everyone. I'm Jill Socrates, Neuro-Oncology Advanced Nurse Practitioner at Clatterbridge Cancer Centre in Liverpool.
And Michael?
Hello everyone, my name is Michael Jenkinson. I'm a Professor of Neurosurgery in Liverpool.
Fantastic, thank you. Our first presentation is from Jill Davis, a consultant neuropathologist from Nottingham. She's going to talk about the new World Health Organization classification of brain tumours, which is absolutely essential and the very essence of how we start thinking about how we treat our patients. Although some of the slides presented look quite complex, Jill's talk as we go through highlights the most important aspects. Over to you, Jill.
Hello there. My name is Gillian Davis and I'm a neuropathologist from Nottingham, and I'm honoured to be invited to talk to you today about recent changes and developments in neuropathology. This is based on the talk given by Professor Kurian at the BNOS meeting in Liverpool in June, and is a 10-minute brief overview of that. So, a little bit about neuropathologists. We are doctors who are part of your team, even though you may never see us. The information we give to your surgeons and oncologists affect what treatments you might actually receive after surgery. We report samples of tumour taken at surgery, look at it down the microscope, like here, to produce the pathology report. After using the microscope, it's often necessary to perform immunohistochemistry using antibodies that turn brown if certain proteins are present. And this is one of the ways we're able to get more information about your tumour. And after recent developments, we've seen the rise of molecular testing, which tell us even more about the individual mutations of a tumour or what family it belongs to. We integrate all this information together to get an overall diagnosis, and this shapes the patient's future management. So what is the WHO tumour classification? Well, these are the guidelines by which pathologists all around the world agree what to call each tumour type. Teams of experts have meetings, evaluate all the available information, research, and then around every 7 years there is a new publication. We call them the blue books, and this is mine here. It's about 555 pages long and they get bigger every edition. This ensures wherever you are diagnosed around the world, the diagnosis is the same, which means your team know they're able to access information about what tumour type it refers to, because we're all calling the same tumours by the same name. So what changed in the 2021 version? Well, there were very straightforward changes, such as how we write the grade number, to giving new names to things we've known as something else, and recognising entirely new entities that previously we either struggled to name or had been given really broad categories. The molecular tests have helped tease out distinct groups, and now we're able to name them. So for the first time, each tumour will have essential criteria needing to be present to call something a certain name. So some tumours will still be diagnosed by looking down the microscope. Now many tumours will require immunohistochemistry and molecular tests for diagnosis. If we take an oligodendroglioma as an example, the essential criteria here listed say there must be an IDH1 gene mutation and a chromosome loss, showing part of chromosome 1 and 19 being lost. So it would be essential for immunohistochemistry and a molecular test to be performed in this case. The 2021 WHO classification recognises the expansion in molecular testing of tumours and develops tumour classification by their genetic characteristics using a range of tests. This busy diagram here demonstrates how diagnosis changes and evolves in tumours that underwent molecular testing at one centre, giving a clarification in the diagnosis and sometimes even a complete change in the diagnosis. To understand our genetic testing, this is a brief introduction to genetics. In the nucleus of every cell, there are 23 pairs of chromosomes, made up of tightly coiled DNA. Genes are segments of DNA that encode the making of a particular protein. Long strands of DNA are packaged around histone proteins, and histones control turning the genes on and off. The expression of genes can also be changed by adding of methyl groups to the DNA without altering the underlying DNA sequence, and this is called epigenetics. All the most recent changes to tumour names and groupings have come about by our greater understanding of how these mechanisms go wrong. Cells become cancerous by gathering genetic alterations. Once the cell is cancerous, dividing rapidly, it allows even more genetic alterations to occur. Understanding what genetic alterations have happened in a tumour is driving the cancer will now be used to classify tumours and increasingly improve treatment, hoping to see more personalised medicine. There are 4 main ways in which a cell's genetic material can change, leading to cancer-changing alterations, and depending on what has gone wrong, there are different molecular tests needed to find these. Along the bottom here, there is firstly a demonstration of Sanger sequencing to detect single nucleotide changes in the IDH1 gene. Next to it, there's a picture of FISH, fluorescent in situ hybridization testing, which looks for fusions and copy number variants in genetic material. And next to there is methylation-specific pyrosequencing, which looks for MGMT methylation, which is performed in gliomas. And once we've diagnosed tumours, we now need to grade them. There have been some changes to how tumours are graded in this new WHO classification. When we diagnose a tumour, we usually give it a grade, and that describes how the cancer cells look under a microscope and reflects how aggressively the tumours behave. A low-grade tumour, like a 1 or a 2, has more normal-looking cells, is less aggressive and more slowly growing. On the other hand, higher-grade tumours have abnormal-looking cells and behave aggressively. As well as changing how we write the number, a small number of tumours have been given new grades, such as the myxopapillary ependymoma, recognising its ability to spread. Another change in CNS tumours have traditionally had a grade assigned to every entry, whereas now there will be a broader group of tumours given the same name but assigned a different grade within that name. So, for example, commonly known gliomas called diffuse astrocytomas grade 2 are now called astrocytomas grade 2. Anaplastic astrocytomas are called astrocytoma grade 3, and secondary glioblastomas are now called astrocytoma grade 4. All these tumours now have the name astrocytoma, but it's just designated its grade increase with the number. There have been modifications of how we think about tumours that have been around for a very long time. If we take, for example, the glioblastoma, there is now only glioblastoma IDH wild type. Any tumour with a mutation in the IDH gene now cannot be called a glioblastoma. But at the same time, having different genetic alterations in a tumour that looks quite well behaved down the microscope can predict it behaving badly, and so now these tumours will be called a glioblastoma. So previously, any tumour with vessel changes and areas of cell death were called glioblastoma. Now we recognise that pattern can actually represent one of any 6 distinct diagnoses. So there are also, in addition, brand new tumours that have made the WHO CNS classification. These haven't just begun to occur, they represent rare tumours that have always been around, but the pathologists have struggled to fit in a named category previously and called the nearest closest thing. Or they have come into existence because we found a clear genetic alteration that defines a subgroup of tumours, so that they've been given their own diagnosis. Now that we've been using methylation profiling, we've been able to build up a database with the molecular fingerprint of all tumours found in the central nervous system. Clever computer scientists then see how the tumours group together, as you can see in this incredibly complex circular diagram. This paper took a group of tumours we call central nervous system primitive neuroectoderm tumours in children and used methylation profiling to pull them into groups with similar molecular fingerprints. It found many were tumour types we already knew, but found 4 entirely new groups, all 4 of which have made the WHO new classification. So after all these changes, what does it actually mean for patients? Well, we're going to have more accurate diagnoses now that will lead to more informed choice for prognosis and therapy. There'll be clinical trials. We'll be able to look at the effects of drugs on patients with much more similar tumours, making results easier to understand and individualise. And using methylation-based classification, the tumour fingerprints will lead to faster diagnosis of difficult to classify disease, potentially saving a lot of time and lab resources. However, all this testing has overwhelmed many molecular labs. There may be a delay in patients getting a final diagnosis while the team wait for results. In rare cases, this may even delay the start of treatment. Pathologists will have to work very closely with the clinical team to understand the treatment implications for some of these new entities. And the final thing I wanted to say to you though is what happens to people diagnosed before 2021. Well, in reality, nothing will change. Even if you have a tumour that would now be called something else, the right diagnosis was the one that we made at the time, using the information available to us at the time. There is the chance though that if a patient had a redo operation, we may now have to call the tumour its new name, but would make it very clear how this relates to the previous diagnosis. And finally, I just wanted to reassure you that many patients are likely to have benefited from molecular testing, even if their tumour was diagnosed before 2021. We've been using these tests for many years now, and they're just becoming officially recognised as part of the diagnostic process. One of the best things about working in the UK is I'm free to request testing that is likely to benefit my patient without worrying about resource or cost to them. So thank you for your time, thank you for listening, and I'll be free to answer any questions now.
My first question is for Louise, and it's just how do these changes affect your treatment of patients?
Yeah, I think so. Yeah, brilliant talk, Jill. Thank you. Obviously, very detailed. And I think that's the first thing to say is that there's a lot you can delve very deep in terms of pathology and molecular tests. But on a day-to-day basis, there are some critical tests that we need to inform a patient of their diagnosis and to create a management plan with them. And I think in my experience of being a consultant oncologist, that's changed in the time I've been a consultant. When I started, we'd get a quick result and be able to tell the patient their diagnosis, discuss what it meant for them, and make a management plan quite quickly. Whereas now sometimes we are giving a provisional diagnosis after a week or two, but needing to sometimes wait a month or more to get the final results. And that is obviously difficult for us in terms of making the plan, and also very difficult for patients because they're being told you've got a brain tumour, but we can't really tell you what that means for you. And I think that's a big thing. Obviously, the good thing for us is that when we do get those molecular results, we are more assured that we know exactly what we're dealing with, and we can try and fine tune our treatment to give the patient the right treatment, whether that's more than we would have done before or less, and that varies from patient to patient. And also just in the going forward to the future, as Jill mentioned, we're going to understand more about molecular changes in individuals' tumours and hopefully get new drugs that we can give targeted treatment for patients in trials and also in all our patients, hopefully in the future.
And Jill, there's a question in the chat here that I'll pose to you before we move on. And it says, does this mean that temozolomide will cease to be a blanket treatment for glioblastoma patients?
Gosh, that possibly is a question that might be better.
Sorry, Louise.
Louise, yeah.
Sorry, Louise.
I mean, I think there are, as we all know, there are trials, and we know that MGMT methylated patients are much more likely to respond to temozolomide, but there's no surety that those that are not methylated do not respond to it to some degree. And certainly we see patients responding to it. So I think that is a question in progress. So at the moment, we don't know, but obviously we're hoping that for those patients who are not methylated, that will be something to replace temozolomide. Whereas at the moment, if we were not to give it, then we don't have other options. So even a small chance of it being useful is worth doing. Okay,
thank you. I'm going to ask a question just before we go on to some of the other questions in the chat to Kaj, Helen, and Jill, and you pick who answers. Obviously, getting the molecular testing takes longer. What are the implications of that for patients?
It's Helen here. I think as soon as you step into the space of being diagnosed with a brain tumour, your whole life becomes surrounded by living with uncertainty. So it's about looking at the strategies you can put in place to help you cope with this. And, being comfortable with uncertainty is not about feeling unsafe. So I think it's about being informed, understanding why it might take a slightly longer to get the definitive diagnosis. And you don't really want patients going down a road of having treatment that won't be effective. And I think if it's, you're transparent in your conversations with patients and they understand why there might be a little bit of a longer wait to get the diagnosis, I think everybody would much prefer that stance.
Okay.
Just to add to that, I think that onus sits with us as the healthcare professionals that should be supporting our patients and their loved ones through this from the start. The importance of communication and explaining this right from the beginning so that we can support them the whole way through. Yes, it is an absolute agonizing wait for patients for when they are waiting for their diagnosis and what's going to come next. And especially as we do know now that it is taking longer, yes, for all of these reasons that we hope will be of a benefit in some way. But I think just being able to support every single need for our patients through that time of waiting, which is so difficult for so many reasons, is important, and we have to step up and be able to do that.
Thank you.
Yeah, no, I completely agree with Jill there. I think that waiting is just sort of like the fear of the unknown. And I think from a medical standpoint, it's good to wait to kind of get that solidified answer. But for patients and their families, it is absolute hell just waiting. I know when my dad went through it, our days were just filled with so much anxiety. We didn't know what tomorrow would bring. We were none the wiser of what was about to unfold. And that was so hard. But then also with the waiting for the answers, I could see him physically declining as well. And then when you're seeing the physical decline of someone you love, sort of mixed with having no answers, it makes the whole process of waiting that little bit more harder. And his balance was one of the first things to go. And just waiting was definitely the hardest part. So definitely managing that side of things and having more of an empathetic view of how you can tell that person that, their life might not be so smooth sailing from here on out is definitely really important. I think for people that are delivering that news from a medical perspective.
Thank you very much. I'm going to take, there's a couple of questions here that are quite similar. And from Tansy and Ted Taylor, it says, will this lead to the development of more specific treatments, and do these new categories change the standard of care delivery based on each new type or subtype? And I think, Louise, probably these are ones for you. And then I do have some for you, Jill, as well. You've just frozen, Louise. Can't hear you.
Sorry. Which one was the one you wanted me to answer? Sorry.
Basically, they're both saying quite similar.
Yeah.
Is it going to change how we treat people? Is it going to be a new standard of care based on each type or subtype?
So I think in some cases that is already happening, yes. You know, a few years ago, we were less able to differentiate between an astrocytoma and an oligodendroglioma, whereas we have very clear guidance on who falls into which category for that, and that will affect the radiation dose to some extent and also the chemotherapy given. And we know more about IDH status, whether someone has a mutant tumour or a wild type tumour. That is becoming to affect on how we manage patients more than it was a few years ago. Yes, certainly. And I think the pathologists very much help guide us on, you know, as these new mutations and molecular changes become apparent, how that can affect our management in terms of if this is more likely to be a more aggressive tumour. Sometimes we upregulate what treatment we would give. So it's working together with our pathologists at the nuanced understanding of the pathology and deciding what's right for that individual patient. So we do individualised treatment now. Obviously, we hope to do it more in the future, but yes, it is happening.
Thank you. There's a one specifically here for you, Jill. It says, if there is no deletion of CDKN2A/B, but there is necrosis and microvascular proliferation in astrocytoma, how is this graded?
Okay, so the microvascular proliferation and necrosis still are the criteria that would make it a grade 4 for us, and a deletion or the absence of deletion doesn't change that. If it was the other way around, if the histology looked good but they had a deletion, that would upgrade it. But no, for now, we're still able to grade on histological features if they're present, and only if they're absent do the presence or absence of certain molecular features come into play.
Okay, thank you. And there's another question here is, will this help DIPG? So Jill, can you just very brief, so just tell us what DIPG is and very briefly tell us if this has now changed.
So DIPG is perhaps a term that probably is more well understood within the brain tumour patient community, but even in the last WHO classification, we were moving to call it something else. So DIPG is the diffuse pontine glioma, where it's a high-grade tumour, and what happened is they were all found to have a certain molecular mutation. Well, it was thought at the time for mutation. In this reiteration of the WHO, it was actually found this was could be usually a mutation, but could be any sort of alteration of a histone protein, specifically a K27M change usually. So we are calling DIPG. Anyone in the brain tumour community would still know what you were talking about if you use DIPG. However, we're also calling these a H3 K27M altered midline glioma now. These are one of the entities that are incredibly well defined within our group, that they remain obviously high-grade tumours for which we continue to look for a specific treatment that will alter the current prognosis.
And there's another couple of questions here about people who had glioblastomas diagnosed back in 2018, and you did cover this in your talk. So, well, actually now, is it now not a glioblastoma? Is it a grade 4 astrocytoma, and does that make any difference? Okay,
so we always thought of a glioblastoma as a high-grade astrocytoma, so where an astrocyte has gone cancerous. And previously we've differentiated between them using subtypes by looking for the presence of an IDH mutation. So currently, if you're known to have an IDH mutation in your in what was called your glioblastoma, this now would be called an astrocytoma under the new guidance. it's yet again, I think for years now, if you were to talk about having a glioblastoma, which some people sometimes regard as called secondary, because the IDH mutation implies it's come from a lower grade tumor initially and has turned into transformed, we sometimes say, into something higher grade. Again, your doctors, your nurse specialists who work in the brain tumor world will absolutely know and understand this entity and what it is. This name change is, it's something we will use going forward for new patients. But I think, the current group of patients who were diagnosed previously, will not be forced to refer to their tumor as something else now.
Okay, thank you very much. I'm going to stop the questions there. We've still got a number of questions, and it may be some of them can be answered directly on the chat. We're going to move on to our next talk.
I'll do that, Andy. I'll work through the questions I can see on the chat.
Wonderful. Thank you very much, Jill. So, and now, as they say, for something completely different, our second presentation is by Anna Crofton, former lead oncology nurse at Walton, who has now moved on to bigger and better things as the deputy lead oncology nurse at Liverpool University Teaching Hospitals. Anna, with Jill, who's on the panel, was instrumental in organising one of the days at the BNOS meeting that looked at all aspects of the patient pathway. And Anna's going to provide an overview of that day and what it can mean for people in the future.
Good evening. Thank you all for joining this evening. My name is Anna Crofton and I'm an advanced nurse practitioner in neuro-oncology based in Liverpool. My presentation is an overview of the patient-centred care session delivered at the conference. This is the first patient feedback session to be held following a British Neuro-Oncology Society conference, so it's an exciting time for healthcare professionals involved in the fight against brain tumours, as we are able to share our ideas and progress within the scientific and clinical world and ask you, those living with brain tumours, your families and your loved ones, to help us shape what good looks like now and in the future. This year's conference was the first face-to-face event for the brain tumour community after the pandemic, and there was a clear message delivered from the conference, and that is that involving patients in decision making and research is key to improving outcomes. A powerful talk from Dave Bolton, long-term glioblastoma survivor, showed us the importance of building resilience, and there was also some important messages to remind us that everything we do should be patient-focused. There was also a pivotal moment during a lively debate around the role of social media within healthcare, when Rebecca, a young ambassador from the Brain Tumour Charity, invited researchers to talk to patients and carers to understand the questions that you have and how they may be answered by multi-professional research. On the second day of the conference, there was a full-day session dedicated to innovative and novel work aimed at improving how people live well with brain tumours. These sessions were in line with the theme of the conference, current, innovative and alternative practice, raising the standard. The session opened with a presentation from allied health professionals who described the role of rehabilitation. Many of us are familiar with the concept of rehabilitation after a treatment and how it can improve mobility, cognitive function, and help people get back to living independently. For those who haven't heard of prehab, then think of it as the time between diagnosis and the beginning of an acute treatment such as surgery or radiotherapy. During this time, the individual may undergo physical and psychological assessments which aim to identify their needs. This then allows healthcare professionals to provide targeted interventions that improve a patient's health to reduce the incidence and the severity of current and future impairments. It is patient-centred and evidence-based and delivered by a team of multi-healthcare professionals, usually led by physiotherapists, occupational therapists, dietitians, and speech and language therapists. It enables people to prepare for their treatment and can help manage expectations. It helps to reduce the body's stress response to intensive treatments, aids recovery, and improves quality of life, including managing fatigue through building strength and stamina. It also helps to reduce social isolation using resources such as social prescribing, and can reduce the length of time people spend in hospital, allowing them to be home with their loved ones sooner. Prehab also provides an opportunity to talk to people about their lifestyle, offer advice and support around physical activity, smoking cessation, nutrition and wellbeing support to help reduce risk factors to health. Prehab is an excellent example of personalised, holistic care. On the day, we heard about exciting developments from hospitals across Liverpool and also the Valindra Centre in Wales, where there's a dedicated neuro-oncology prehab service, and how the interventions they provide have a positive outcome on the experience for patients. We are now looking to continue to build on the great work showcased at BNOS by working closely with the brain tumour charities and the Tessa Child Foundation to understand how we can make prehab accessible to all. The neuropsychology team in Manchester described the dedicated support and intervention they provide to patients with brain tumours. We know through some of the work carried out by the Tessa Child Foundation through the Centre of Excellence programme that access to neuropsychology is varied, and it can often be difficult for patients to access not only neuropsychology but psychological support in general. Cognitive impairment such as problems with memory, articulation, thought processing, problem solving and decision making is something we see in most patients who have brain tumours. It can have a massive impact on day-to-day life and is reported to be the greatest cause of burden to affect patients and loved ones. Along with this, psychological reactions to diagnosis, treatment and uncertainty about the future often includes acute distress, anxiety and depression, frustrations and sometimes behavioural changes. These symptoms can have an impact on how people cope with treatments and can negatively influence quality of life. Clinical neuropsychologists have a wealth of experience in working therapeutically with people who have brain tumours and can work with individuals and their loved ones to help them to better understand how to adapt and overcome difficulties and to develop skills to overcome stressful situations. The Manchester team have a wealth of experience in assessing patients and helping to set goals in order to achieve positive outcomes and improve quality of life. This can also have a positive impact on helping people to maintain positive relationships and even get back to education or employment and prevent social isolation. This session brought about a debate on how we can work nationally to bring about change and action, working alongside the Tessa Child Foundation and charities to put access to neuropsychology high on the agenda. Following on from prehab, we heard about a pilot project in Liverpool that is aiming to improve the information, support and optimisation of symptoms with patients at diagnosis. 62% of patients with a brain tumour are diagnosed through an emergency route, usually through emergency departments. As neurosurgery is a specialist service, not all general hospitals have neurosurgery on site, and usually patients have to travel to another hospital to see specialists. The wait between that time can often be 1 to 2 weeks, which we know can be a dark and difficult place. The effects of being diagnosed with a brain tumour can manifest in many ways. Physical symptoms such as weakness, speech problems, visual problems and seizures, but also the uncertainty about the future, financial concerns and worry about loved ones. In 2019, research showed that the communication of a brain tumour diagnosis was described as a negative experience. Patients experienced difficulties with the understanding of information provided at diagnosis, and patients and loved ones felt low levels of psychological support, rehabilitation and supportive care. The Walton Centre in Liverpool have worked closely with St Helens and Knowsley Hospital, in particular the emergency department and the acute oncology team, to provide education, guidelines and a clear pathway from diagnosis. This includes guidelines for the clinical management of symptoms such as steroid management and advice regarding anti-epileptic medication, and education for the emergency department and acute oncology team on the initial management of patients diagnosed with brain tumours, and this also covered giving people the right information at diagnosis. The acute oncology team have taken on the role of the key worker, meaning the patients and loved ones have a point of contact for support and information. This also helps with communication between hospitals, when arranging appointments and sharing clinical information. It also allows everybody diagnosed with a brain tumour access to a specialist to understand their diagnosis, even if there aren't any treatment options. So far, the feedback from patients has been positive. The team are continuing to collect information and have support from Cheshire and Merseyside Cancer Alliance to roll this out across the region. The team are also presenting this work nationally with the hope that this can be modelled elsewhere. After surgery, people leave hospital to recover before undergoing further treatment. At this point, people can find themselves at home, recovering, life has changed, unable to do normal day-to-day activities such as working and driving, and interacting with loved ones can be challenging as the future is uncertain. Rohit Sinha, Brains Trust and colleagues in Cambridge have undertaken novel research into understanding how glioblastoma and the treatments we offer to control them affect the white matter tracts within the brain. White matter tracts are areas of brain tissue that pass messages to other areas of the brain, and if damaged, can affect how well the brain recognises emotions, often leading to social withdrawal and isolation. Using technology to test cognition, they have found that people with glioblastoma had significantly worse emotion recognition function after surgery compared to before. This work is being used to set up further research into social cognition and rehabilitation for people with glioblastoma. This research will go a long way to helping people to have their best day possible, underpinning prehabilitation and rehabilitation interventions by understanding the impact treatments can have on these important structures within the brain. The day concluded with the team from King's College in London presenting their work using a combination of transmagnetic stimulation, psychological support and neurocognitive brain training to improve enhanced recovery after brain surgery. This is an MDT approach providing holistic personalised care to positively impact outcome and quality of life. This prompted lively discussion about the multi-professional roles and the important part everyone plays in supporting patients and their loved ones living with brain tumours. So in summary, the patient-centred care session highlighted the incredible and important work that is to understand not only how to treat brain tumours, but how we support people to live well with brain tumours. It has been the catalyst for conversations on the importance of access to rehabilitation, neuropsychology and good information and support, always underpinned by the question, what matters to you? Thank you for listening.
Thanks, Anna. That was really good, and obviously something quite different than the previous talk. I'm going to start with a question for Paul Grundy. I don't know, Paul, you've been heavily involved in NHS England, Public Health England, about patient pathways. Is there anything you'd like to comment on Anna's talk, how the sort of things that can be moved forward or ways of moving that forward around the country?
Yeah, I think there's some really important and useful information in that talk. Look, one thing, as you know, I'm particularly passionate about, which I think is something we do quite well, but maybe not as well as we could do, is around shared decision making and involving patients very actively in those very honest conversations about their diagnosis and treatment options up front. And I know this is something Helen and I have been working on together and will continue to do so, but I still see there's quite a mixed practice around the country. I also think there's something in that prehabilitation. So I suppose traditionally we've got patients coming in perhaps with malignant brain tumours. They're coming in on quite a fast pathway into care. And I wondered about the rationale and appropriateness of prehabilitation in that sort of time frame. In fact, if you talk this through with the experts in perioperative medicine, they don't need very long to optimise a patient's health in order to get the best outcomes and recovery for those patients, probably only a week. So I think there's definitely something in it. I think we can have better conversations with our patients. I think we can get patients as fit as we can before we see and treat them and get the best possible outcomes then for patients and the outcomes that they want to achieve with that honest information they've been given up front.
I suppose a follow-up question to that then is, with the challenge of staffing and funding within the NHS, how do you prioritise for this group of patients and try and move that forward?
I guess for me, it's about having a passionate team of interested experts, isn't it, in any department where that is your raison d'etre, that is the reason that you come to work in the day, that is to look after and care for and give the best for patients with brain tumours and be an advocate for them. And I think most of the people on this meeting will probably understand that. And I think that subspecialisation in neurosurgery, that's one of the things it's given us, that really being able to really get behind the needs of our patients. And quite a rare group of patients overall, aren't there? But I think focusing your efforts on that group is something quite powerful.
Helen, can I pass over to you for comment?
I'm sorry, Andy, I was busy responding to Paul's question about grade 2s and how we describe them in the community. Could you just very quickly ask me again?
It was just to comment on Anna's presentation about how we can move some of the really fantastic things they've talked about, prehabilitation, psychology, all these sorts of things, but move it forward on a national scale when we have issues with staffing challenges and funding issues.
Yeah, so Paul is absolutely right. It's about shared decision making. And I think there is in some areas, it's the joy of local. There is so much on offer, but in others, there's a real paucity of support for patients. And it really is about using those shared decision making conversations in the clinic with patients to identify what really matters to them. And then looking and exploring with them the behaviour changes they need to make, which may only be 1 or 2 things to achieve their best possible day. And we think with the right conversations that can happen. But the other thing, of course, too, is if you're diagnosed with a tumour that needs urgent surgery, you're not going to have time to have that prehab. And then I think really the focus needs to shift on what are the support services you need to address things like Anna pointed out with isolation and things like that when you are discharged from hospital, because that's when patients feel they've fallen off the back of the boat.
Okay, well, I'm going to pass it over to Anna, if I may. Anna, with patients with malignant tumours, do they not have enough time for prehab?
No, I think, as Paul says, there's the perioperative team don't need that long to optimise patients, but I think there's also something in the work that we've done from diagnosis in general hospitals around optimisation of patients and starting it from diagnosis, so not just when patients get to a specialist centre. So I think there's a role for everybody, not just the neurosurgical centres.
Okay, thank you.
Can I just make one other comment on the question around how do we do this around staffing and resource? I think what we don't do very well is celebrate our outcomes around some of these initiatives. So, you know, how do we see that it improves patient outcome? How do we see that it improves quality of life, and how do we showcase that and celebrate it? And I think using, you know, the work that Helen does and the Brain Tumour Charity and even the likes of Macmillan to showcase that and to support and to provide those outcomes will be really helpful.
Okay, thank you. And I think there's a question about can the way prehab is given be adjusted depending on the time frame, and I think you've answered that quite nicely. Kaj, I wanted to ask you a question. Looking at that, what sort of areas do you think would be priorities from a patient point of view, with sort of a number of the things that Anna has mentioned? Would anything struck you particularly?
So all of it was very striking, all very interesting. I think from my perspective though, and my own experiences and sort of what I went through with my father, just that level of empathy and the way that news is actually delivered is something that I feel like could be improved upon. It's very easy to get sort of sucked into sort of a black clinical hole of all these like sort of prototypes and all these like acronyms that I honestly have no clue about, but just the way you sort of deliver news to people who are sort of entering that sort of end of life phase is so important. And also that support for families is very pivotal around that time.
Okay, thank you. Jill, I'm going to ask you a question. There's a question in the chat where somebody has said that can they get support for anxiety, mental health issues and anxiety for them and not just the patient, but the family around it. Is there anything you can advise them where they can?
Well, I guess obviously, again, this is one of the things we're saying, every centre and every unit is different in terms of what they provide. What we should find nationally is that most clinical nurse specialists at band 7 or above are trained to assess the psychology of our patients and to be able to provide level 2 interventions. So that sort of takes us to a certain point of the support that we are able to provide, and then understanding those pathways of referral and how to get that support quickly for our patients, because I think it's important to recognise that patients and their mental health it's vital that we support that from day one, and it will change as they go through diagnosis, as they go through surgery, as we support them through prehab, rehab, treatment, not going through treatment. There are so many different factors that can affect mental health. So I guess a big part of it is about what is available in each centre. You know, one of the examples that Anna mentioned was the work that they're doing at King's, looking at neurocognition and psychological support, and they start that at their pre-assessment clinic from day one of patients coming to discuss surgery, but they're also able to continue that through the whole way through treatment. And I understand that they've now developed some actual psychological support workshops, which is a fantastic initiative. I wonder whether, again, looking at nationally how we can bring this in so that it's available to every patient who is going through this in every centre and every location. That's really what I think we all want to do as people with an interest in supporting it. I would say that most cancer centres do have access to psychological medicine, and it's really, really important, if you've got a key worker, which everybody should have, that you feel that you've got the opportunity to discuss your mental health and your emotional needs, not just for you as the person who is living with or going through treatment for a brain tumour, but also for the people who love you and care for you. It's so important that people feel that they can have that conversation, and that us as healthcare professionals know the routes to get in quickly.
Thank you. I'm going to pass the question now over to Kaj and Helen. So what do you think is the role of the brain tumour charities? Because obviously, as everyone said, there is some variation in regions for this sort of support and help.
So we always believe that charities are out there to close the social aspiration gap. So we feel the things, you know, that patients need that may not be able to be delivered by the NHS. So we have rapid access counselling, we do coaching to help people bring clarity and build resilience. And just, you know, our goal is that with the right conversations, we think that people can have their best possible day, even at end of life care, if you're having the right conversations with the right person. And I think, you know, coming from your perspective, Andy, it's really hard when you're trying to nurture hope when potentially the future looks bleak. And I think for patients and caregivers, just to have another outlet, another sounding board is absolutely key. So I think the charities have a huge role here, but, you know, you have to work very closely with the community to identify where the gaps are so that you're not duplicating.
Thank you. Kaj?
Yeah, no, I'm completely on board with what Helen just said there. I think that charities are so pivotal to sort of bring people together. And also when you're going through something as disheartening as a loved one going through a diagnosis, it's so easy to feel isolated and lonely. So when you're sort of in touch with a charity, you are meeting like-minded people who have unfortunately gone through similar things such as you. And I think from my perspective, being a young person, meeting other young people that were like-minded really helped me through my grief as well. So it's not just whilst I was going through sort of the pain with my dad, but sort of the aftermath of dealing with those feelings and those emotions, having people that can sort of empathise with what I was really going through helped. And they do so much sort of groundbreaking work and really sort of support people from that emotional perspective too. So I think that it's a very, very important aspect.
And was that mainly through social media?
Yeah, mainly. So being a sort of young ambassador, there are sort of a group of us, and you can sort of meet outside of that as well as keeping in touch online and on social media too. But there are resources everywhere, whether it be sort of on the website, or if you need a chat, there's always helplines available too. So wherever you want the support, there will always be some form of resource available.
Andy, I think Anna wanted to come in again.
Okay, please, Anna.
Yeah, it was just to note that there is a community workforce out there as well, a non-clinical workforce of social prescribers who can help with, some of the social needs of people who are living with brain tumours that, prior to moving to my neuro, I didn't really know an awful lot about, but actually can see the real benefit that these roles and community navigators can have on reducing social isolation and anxiety, and taking some of the general worries away by some intervention.
Okay, thank you very much. Thank you very much for all that and for people's questions. We're going to move on now to our next talk. And our next talk is again on quite a different theme. Ryan Matthew is a young, dynamic consultant neurosurgeon from Leeds, says I, a slightly older, less dynamic one. He's going to talk about some of the new stuff coming in neurosurgery in Leeds, where he works, most of which he uses or is developed. Over to you, Ryan.
Good evening, ladies and gentlemen, and many thanks for this opportunity from BNOS and the PPI groups to talk to you about some of the exciting developments and work that we're doing in Leeds, looking at new and emerging technologies in brain tumour surgery. My name's Ryan Matthew. I'm an academic neurosurgeon. I mostly specialise in brain tumours, and I also run a research programme looking at new technologies and a lab looking at new cures for brain cancer. So what are we trying to achieve when we take out brain tumours? Well, of course, we want to take out as much of the tumour as possible, but we also want to leave patients as well as possible. But during my research journey, I thought, could there be more that we are doing before surgery, during the surgery, and after the surgery? And actually, I have three aims. One, we need more information as the operation progresses. We need to leave less tumour behind, and at the end of surgery, we want to be able to deliver treatments right there, right then, into the hole that we've just made. So of course we know that patients, their journeys start in the community, going along one day and suddenly finding out they've got a brain tumour. They then have to come into a hospital and speak to us before their surgery. They have their surgery, and then after surgery, we want to try and improve their outcomes. Looking forward to life, LFTL. So we thought, wonder if we could get speech, language, memory, cognition, behaviour to help us detect whether patients might have a tumour and might need a scan. This all came about because I'd often see patients in clinic telling us that themselves or their relatives had noticed they just hadn't been themselves for some time. So if we could show that there was a difference, then maybe we could get an early scan. And these are relatively cheap scanners on wheels that we can have in supermarkets or GP surgeries, and within 5 to 10 minutes you can have a scan and easily try and pick up whether there might be a brain tumour. Of course, for children this is fantastic because their parents can stay with them, which they traditionally wouldn't be able to do in a normal MRI scan. This is a really exciting technology. So what can we do before surgery? Well, before surgery, we need to work as a team. We need to give more information to our patients. And so we put these headsets on and we're able to see the scans right in front of us, whether that be working as a team to see how we can test patients and remove the tumour, or working with patients to show them exactly where their tumours are so that we can give them more information about the risks, the benefits, how it might grow back, and so on like that. We also use planning. So this is me before an operation looking at a hologram of the tumour I'm about to operate on. And what's really key is the coloured areas show you the important tracks, such as speech and motor, that I'm trying to avoid during the operation. This is again a headset that I put on, and sometimes 5 or 10 minutes before an operation, I can have a quick revision of the anatomy itself. We then move on to technologies during the surgery. What we really want to do is to make all this technology and all of these devices talk to each other. So we have microscopes that are very expensive, combined with our navigation systems, the sat-nav for the brain. We put these two things together, and really precisely we can see where the tumour is, and it can direct us in order to remove it as best as possible. We also give the tumours dye, which makes them glow and means that we can see them better. So these are pictures from inside an operation, and you can see here a lump, and this bit that glows is the cancerous portion of the tumour. You can also see a lump here, and you can see that different bits of it glow. So we can make sure we send the right bit to the pathologists, and we can analyse the right bit. The other thing we can do is take a piece of this tumour and scan it quickly in the operating room to see whether it's still tumour or whether we're starting to get into healthy brain. Remember what I said about trying to remove as much tumour as possible, but leaving patients as well as possible. So this was a world's first at Leeds. We used a flatbed scanner, just like you might have next to your PC, and we put a piece of tissue on it. Within a minute, we get a special type of image which shows us whether it's still tumour and we should keep operating or whether we should stop. We're going to take this one step further, and we're very lucky that our hospital charity has funded a special probe. So this looks like a pen, and at the end of the pen it has a really high resolution scanner. And this scanner allows us to pass the pen around the inside of the hole that we've made when we think we've finished, and it will pick up extra bits of tumour that we may still have left behind, and that allows us to more precisely take that out. So once we think we've done as much as possible, we've removed as much tumour as possible, as safely as possible, and used these detection tools to see whether there's anything left, we have something called intraoperative radiotherapy. So this is where we place this ball inside the hole where the tumour was, and we deliver radiotherapy right there, right then, and try and kill off the extra cells that are left behind in and around the cavity. The beauty of this technology is we don't have to penetrate the skull with the radiation, and therefore we can reduce the dose. The advantage of that is that we then minimize damage caused by radiation to healthy brain. Of course, we want to train the next generation as well in all of these technologies. So these are some trainees and engineers sitting in my office in a completely different part of the hospital, and they're able to watch what's going on in theatre, talk to us, we can show them what we're seeing, and we can help train the next generation of brain tumour surgeons. This is really important. So we then talk about what happens after surgery. Patients may have neurological problems, they may need therapy to help them recover, and they may spend a long time in hospital. So we thought, let's make it fun. This uses augmented reality, where you put a headset on and you have to try and catch these holograms. There's another game that we can play, which is called Beat Saber. This is one of my favorite games. So this is putting another type of headset on, and it's trying to cut these blocks in half and up and down. It's not normally as fast as that. What this teaches patients, we hope, is how to use their left and right hand together, how to retail their brain, retrain their brain in the motions required for functions that we find so important from day to day. And these are things that are safe to do at the bedside and also mean that patients can be having therapy when therapists aren't available, because we have a real shortage of therapists in the NHS. Some of my patients, and lots of patients with brain tumours, spend a very long time in hospital, and that can be really miserable because they miss their house, they miss their pets, they miss their family, they miss the creature comforts that make us feel human. So we thought, how about putting a headset on and going home? Of course, patients aren't actually going home, they're just seeing images of their home and making them feel like they're back at home briefly. What we want to know is whether these simple and relatively cheap technologies might improve well-being and make people feel better. The other thing about brain tumours is lots of them need more therapy afterwards. So chemotherapy, radiotherapy, but we know it doesn't always work. This was a really powerful statement that one of my former patients said to me. If I had known that my tumour would progress during radiotherapy, I would never have gone for it. So we in the lab are working on developing a device that takes a real piece of tumour from a patient and tries to predict the way that that might respond to chemotherapy and radiotherapy. If hospitals had this, they could tell oncologists and their surgeons about whether it's worth going for it or not. So let me take you through the future of what it might feel like. Somebody gets a headache, a person gets a headache. They go to their GP surgery, and while they're sitting there, they talk into their mobile phone. By the time they see their GP, the GP has an idea whether this person might have a brain tumour. They have a scan using a portable scanner, and then if a brain tumour is picked up, they go and see their neurosurgeon. We use technologies to improve and see the tumour. We take out as much as possible, leaving as little as possible. We predict whether this is likely to respond to treatment. We give radiotherapy right there, right then to blast what might be left. And then we intensively rehab patients to give them the very best outcome possible. Much of this is how I see the exciting future of brain tumour surgery. I want to thank the team, without whom it couldn't be possible. We have an enormous team at Leeds now working purely on brain tumours, and this is really exciting right across the spectrum. And of course, all of our collaborators, both at Leeds, throughout the UK and internationally, and of course our funders. And I'll leave it there and I'd be delighted to take questions.
Right, thank you. Fantastic talk, Ryan. Really good, really interesting. I'm going to open the questions firstly to Professor Jenkinson. You're very clever, and would you like to just give us a view as to, Ryan's given us a lot of really interesting ideas, a lot of things that have been developed in Leeds. Some of them are available elsewhere. If there was one thing that you'd say, oh, that should be the thing that we take around the country, what would it be?
Yeah, that's a very good question. Before I answer that, I would also agree with your statement that he is younger and you are older. So I think you're right there. I mean, where to start? There's half a dozen options there. I suspect one of the critical things for most people who have been diagnosed with brain tumours is the time it takes for them to be diagnosed. So if you can have a simple technology that's accessible via your mobile phone that would allow people to report symptoms or get analysis of their voice, that would mean they get more rapid access to imaging and therefore an earlier diagnosis, I think that would make a big difference. I think it's impossible to choose one that would make a single big difference. It's going to be all those technologies added together are going to make an iterative improvement potentially in outcomes, because we know, the only modifiable factor that we currently have for people with brain tumours is how much tumour we can take out. We can't change anything else. We can't change your age, how well you are, what the clever molecular genetics and pathology is, but the one thing we can make a difference to is how much we can take out. So if Ryan Matthew can improve how we do this, and we can do it safely and with good rehab, then I think that's the one thing we should be driving towards in the first instance, all the whilst people are looking for newer drugs, newer treatments to tackle the remaining disease.
Thank you. There's some questions in the chat for you, Ryan. So I think you're answering some of them. I guess the question is how far along in development, because you've talked about a lot of things, which things are here now? You've sort of hinted at a number of in development. Which things could you turn now and sort of be around the country?
So it is a mixture, and that was the idea of presenting it, really. So there are some of these things are absolutely in clinical development, in clinical use right now. So it's part of our workflow in Leeds and could be available to others. So the pre-op planning, the holograms, the ability to glow the tumour, the integrated technologies intraoperatively. These are all technologies that are ready to go. Some of them are just on the cusp of being available, and we are, the whole idea of us testing them is so that we can see, to answer Michael's question about whether they're actually useful and they could have an impact. So they're ready to go and they might be available to buy, but we don't want people to spend a lot of money and waste a lot of money in the NHS. So the idea is that we work out whether they can have impact. So the portable MRI scanner is very close to ready to be in clinical use. We're going to trial that. The neuro rehab, we've just got funding to start the trial using the headsets to see if that makes a difference. And then other technologies are very much at a research phase. So when we talk about voice detection and tumor treatment prediction, they're very much still in a lab research phase. They're not close to clinical translation yet. But the idea is to have this pipeline and see where we can impact patients all along the pipeline.
Thank you. I've got to ask a question for Louise, because you did talk about patients being, not happy that they had their radiotherapy and this new intracavity radiotherapy thing. Louise, any comments?
I think obviously radiotherapy for me is always weighing up for the patient the likelihood they're going to get benefit. Certainly in the short term, if we get it right, which we need to be careful we do it as often as we can, then most patients tolerate their radiotherapy, certainly in the short term, reasonably well. Obviously there'll be exceptions to that. And yes, unfortunately, there are long-term side effects for some patients, and some of those things I saw in the chat. There was something about some problem with hearing, and those can be difficult to manage. Often side effects that can be put to radiotherapy, and certainly are often in part due to radiotherapy, are multifactorial. So things like short-term memory can be due to obviously surgeries and scarring, anti-epileptic medications, general fatigue, tumor, activity. So I think it's often difficult to tease out which of the various things cause some of these side effects, but certainly radiotherapy is responsible for some of them. In terms of the intracavity radiotherapy, obviously it's very interesting. It's a very different way to think about treating glioblastomas, because as we know at the moment, when we treat with radiotherapy, we treat a 2 centimetre margin around the tumour with our radiation. And as Ryan mentioned, there's the rest of the brain, the radiation travels through to get that targeted area. Obviously, intraoperative radiotherapy is only delivering radiotherapy to a rind, a very small rind of brain tissue, which is a different way of approaching the kind of pathological process of how these tumours tend to regrow. But yeah, it's very interesting. Obviously, in breast cancer, this is something that's been done previously in trials, and going forward, there may be a combination of intraoperative and post-operative radiotherapy in the standard setting. But it's an interesting project.
And Ryan, there's a question here about in-theatre scanner to check for healthy brain tissue. Would you like to answer that? How can the scanner act in a way that seems more histopathological, it says?
Yeah, so that's exactly what the scanner on the end of the probe does. So what it allows us to do is to sweep the cavity and try and detect healthy cells from cancerous cells. The flatbed scanner does the same, but of course we actually have to take the tissue out. So if you took the tissue out and it happened to be healthy, then you'd remove some healthy tissue. So these are all, none of these technologies are a golden bullet. They're all to be used together to try and increase the amount of information we have at the time of surgery.
Okay, thank you. Kaj, I'm going to over to you. Anything that you saw that you thought, wow, I wish that was available around where we were. That's something that I think needs to be developed.
Yeah, oh my God, all of it, to be honest. I think from when sort of my dad was going through the treatment, it actually quite shocked me how quickly the doctors gave up on him. He actually went through like 2 rounds of chemotherapy and surgery until they handed him his end of life prognosis. So the fact that there's so much amazing technology out there that could potentially change people's lives is so like heartwarming to see. And I really hope that it comes to fruition really soon. And yeah, really, really nice job there, Ryan.
Okay. And Helen, anything you'd like to comment?
Yeah, I just think with all of this, I want to come back to the comment about its progress across a lot of areas that's probably going to make the breakthrough that we need, which comes back to like the David Brailsford with the tour, you know, the British cycling tour. When he was brought in, he looked across the whole landscape to see where the small changes could be made. And when you look at them aggregatively, it's the marginal gains, you can make huge progress. So it's really exciting to hear all of these things. I think to Stephen Price at EANO, the European Association of Neuro-Oncology, flagged that actually looking at tumour margins in surgery was going to be quite a key player in all of this.
Okay, thank you. And Paul, I'm going to open it to you. How do we move this forward again on a national scale? Ryan's doing lots of good stuff in Leeds. There's lots of good stuff going on elsewhere. How do we move this forward nationally?
I think we do need some sort of coordinated and scientific effort, as others have said, isn't it? Because some of these things look very appealing up front, but when we test them and trial them, they perhaps don't always deliver the benefits that we might have expected. So as a community, you know, we need to act responsibly, don't we? And together to collect data to hopefully demonstrate the benefit that these technologies will have. And I think that's where the sort of clinical trials come out of the initial, you know, early impression that something might be of great value. We need then to get together, don't we, and resource those trials and test those theories and prove, you know, what are the things that are going to make the biggest difference for our patients going forward. So we have people like Michael and Ryan in the room who are experts in doing just that, pulling together clinical trials across the whole country, because you need quite often a significant number of patients in those trials studied for a significant period of time to prove the benefit. And therefore that needs a concerted national or even multinational effort.
And it's always hard with technology because you've got to introduce the technology first, you know, so it is complex. It's even harder when you're looking at patient cohorts for neurosurgery. You can't say to one patient, well, you're not going to have it, when potentially it might be beneficial. But we've got the Future GB trial too, which is comparing some of the new modalities that have come in.
Michael, comment about clinical trials in these technologies?
Yes, always very challenging, because you can have products that are designated as safe, you know, they're CE marked, but you need some caution before you introduce new technologies or new techniques. There's a tendency for them to be rapidly adopted, or Ryan Matthew will publish great results from them, then people will adopt them and use them for more indications that they've been proven for, and then they can fall out of favor. And sometimes you can lose technologies that were beneficial that should really have made the grade. So it's just, you know, there is a whole framework around making sure this happens properly called the ideal framework. So there are methodologies that will allow you to assess technologies properly.
And just to comment very briefly, Andy, we are using the ideal framework. So the abstracts that we've submitted to SNO use an ideal stage for all of these technologies. So, and I couldn't agree more with Paul and Michael that the idea is that we pilot them possibly at Leeds, see if they show some early promise, but then we have to work together as a national cohort to see whether they're really beneficial. What we're not interested in is the technology itself. We're interested in the impact it can have on patients.
Okay, thank you very much. I'm going to move on to, that was great, great discussion. Thank you, everybody. I'm going to move on to our fourth and final talks, which we're going to run together. These talks are for new treatments for people with glioblastoma. And for those who don't know, glioblastoma is an aggressive brain cancer and treatment options are limited. Farouk, who's a consultant neurosurgeon in Liverpool, is talking about tumour treating fields, and Ash, Professor of Neurosurgery at King's in London, about dendritic cell therapy. Neither treatment is available on the NHS at present, unfortunately, and they're expensive, but they may be available in the future. Both talks do talk about prognosis and life expectancy for this group of patients, so be warned if you do not wish to know that sort of information, you may not wish to stay for these talks.
Hi there, my name is Farouk Olubajo. I'm a consultant neurosurgeon at the Walton Centre in Liverpool, and I'm going to be talking to you about tumour treating fields. So, what are tumour treating fields? Well, tumour treating fields are the constant exposure of low intensity alternating electrical fields to the brain, and as a result, the brain tumour. This electrical field is thought to disrupt the ability of cancer cells to divide, and as such slow down a brain tumor's growth. The way it works is you have microarray or transducer electrodes which are attached to the scalp, and this emit the electrical fields, and the electrical fields disrupt important proteins that are used for cell division, and because the cells can't divide, they die. Interestingly enough, most of our brain cells have stopped dividing. Most of the division that happens in brain cells happens during development and as we're growing. And when in an adult, they're not dividing. And so this treatment focuses primarily on the cancer cells, i.e. it's a treatment that does not affect the underlying, the brain, but the cancer cells. So it's quite focused, which is good. What does it look like? Well, you have these transducer arrays that are attached to the shade scalp with this adhesive dressing, and the transducer arrays are connected to wires and plugged into a battery. And the battery is about the size of a book, and it fits into a bag, and the bag can be carried as a backpack or across the shoulder bag. And the device includes multiple batteries and a charging station, and people are supposed to wear it for about 18 hours a day. But you can unplug it for periods of time, so to shower and things. And this is what it looks like. So you have the transducers array where the electrodes are attached to the scalp. You have the wiring that's attached to the bag, and attached to the battery, and the battery goes into the bag, and the bag can be carried around because the thought is this should be a portable treatment, so you can go for walks, you can cover the scalp with a headband or dressing, and this means you can carry on with the activities as normal. The question is, does it work? And it is currently licensed in glioblastoma, and that is because it has been proven to work. TTF has been compared with standard treatment, and it's been shown to have a survival benefit of about 4.9 months compared to standard treatment alone. So when patients were randomly assigned into those who had tumor treatment fields and chemotherapy and radiotherapy, and they were compared to those patients who had only chemotherapy and radiotherapy, and the patients with tumor treatment fields did much better. Multiple studies have since confirmed that not only is it efficacious, it works, but it is also safe with a small side effect profile. And in the UK, we at the Walton Centre were fortunate enough to be involved in the first pilot study on TTF in the UK patients, and we had 9 patients who were able to utilise the TTF machines. And we compared those to patients who didn't have TTF, and we found a survival benefit of about 3.3 months. As well as it being providing some survival benefit, we also found that it had a very minimal side effects. The main side effect that patients complained about was of skin irritation, and you can see in this pie chart that actually 41% of patients did not have any skin irritation, and of those who did have skin irritation, it was mild in most of them and only moderate in a small proportion. Patients were also able to carry out most of the activities, but the device did affect things like showering and bathing, exercise and sports. A large group of patients actually said that it didn't affect any activities, but some people were troubled and affected by the device. So ultimately, we have a device and a treatment that is effective and safe and targets tumor cells over brain cells. So why is it not being widespread? Why is it not widely used? Well, the reason is because of cost. It's a very expensive device, and it's been evaluated by the big wigs in NICE, which is the National Institute for Clinical Excellence, and they found that it is not as cost effective as other treatments. And what they mean by that is when they looked at TTF treatment, they found that it provided about 4 months extra survival, but this was at an additional cost of 185,000 euros per patient. When you compared this to other treatments like temozolomide, which is one of the first-line chemotherapy drugs used in glioblastoma, that cost about 6% of what Tumour treatment fields cost. And as such, NICE did not approve Tumour treatment fields for UK patients, and as a result, it's not available in the NHS. So what does the future hold for Tumour treatment fields? Well, we need the cost to come down substantially before it can be available to the wider public. Probably reduce manufacturer cost or competing devices when the patent runs out would allow costs to run down, will allow us to drive down costs for TTF in the future. And once that happens, then it'll be widely available. There is also a study called the Trident study that's upcoming that will be available to UK patients, newly diagnosed UK GBM patients. And the study looks at whether Tumour treatment fields can be used either prior to radiotherapy and chemotherapy or after radiotherapy and chemotherapy. And this is a study that should be coming up soon for patients. So that's Tumour treatment fields. It's the constant exposure of electrical fields to the brain and brain tumour. It is an effective treatment but not a cure for glioblastoma, and it is relatively well tolerated with minimal side effects. But currently it is too costly, and as such it is not available to patients in the UK. But there is the Trident trial that hopefully would allow patients access to this treatment. That's all I was going to say. I will be available for questions later on. Thank you.
We're going to move straight on to Ash's talk.
Good evening all. It's a distinct pleasure to be here tonight to talk to you about dendritic cell treatment. Particularly grateful to the organizers, Andrew Broadbelt, for asking me to be here this evening. So glioblastomas, as you know, the most malignant type of tumor known to man. Why? Because from a surgical point of view, it is a highly infiltrative tumor, which means that surgery can never give us the full answer. From an oncological point of view, is extremely heterogeneous, which again means that those blanket forms of treatment, such as radiotherapy and chemotherapy, again cannot give us the full answer here. So that means that since a seminal work of Roger Stube in 2005, when he added temozolomide chemotherapy to the radiation therapy and surgery that patients were receiving at the time, and gaining a 2.5 month survival advantage, there has been really little progress in terms of outcome for these patients. What does that mean? It means that survival remains poor, with a median overall survival of around 15 to 17 months, the tumor that almost invariably recurs, and very poor 5-year survival of less than 5%. In fact, when you look at the literature, it is really disappointing. There has not been any systemic treatment for the last 17 years with any meaningful impact on the outcome of these patients. And when we look at the patients with recurrent glioblastoma, this is even more abysmal. For 27 years, they have not had any new treatment for this cohort of patients. So with this background, let me tell you a little bit about DCVax and also present you the results of our phase 3 trial. So what is DCVax? Well, DCVax is a personalized form of treatment. Basically, the idea is that you harness the power of the patient's own immune system against patient's own tumor. So look, for the last few years, we've learned so much about the power of the immune system. In the short period of 2 or 3 years since the COVID, our immune system has been adapted to be able to cope with this very dangerous virus. So why not use the power of immune system to combat our own tumors? So that's the idea. So how do we do the DC vaccine? Well, the first stage is surgery. So that's why as a surgeon, I have always been involved with this trial. The first stage is the surgery, you remove the patient's tumor, and then that's processed to produce lysates, which has got the proteins and antigens of the tumor. The next step is to do the apheresis. So that's how we obtain the white cells from the patient's blood, specifically the dendritic cells, which are the antigen-presenting cells of the immune system. And then there is a vaccine production phase where the antigens, the lysates, are combined with these dendritic cells, and this is then injected as a series of vaccinations intradermally. So no need to inject the vaccine into the tumor. This is injected intradermally. And then the idea is that these cells, the antigen-presenting cells, which have been educated and have been loaded, if you like, with patients' antigen from the tumor, will then go and educate the rest of the immune system, and in particular the T cells, which will then combat the residual tumor. So that's the theory behind this personalized form of treatment. So let me show you some of our trial data. So this is the treatment, as I mentioned to you, autologous dendritic cells, which is really combined with patients' own tumor, even intradermally. Trial design of double-blind randomized trial with crossover, primary endpoint, overall survival, a truly multi-center study, 331 patients, so one of the largest of its kind of this type of trials for patients with glioblastoma across 2 continents. It's a complicated picture, but just to summarize it for you. So as I said, the first step is surgery, and then once the patient have recovered from the operation, typically around 2 or 3 weeks after, they have the apheresis, we harvest the dendritic cells, the white cells from the patients. And then there is a 6 weeks or so vaccine production phase, during which patients went on to have the standard concomitant phase of the STU protocol chemoradiation. So by the time they finished that, the vaccine was ready for them. They were randomized to placebo versus treatment arm. And then the injections, the vaccines were given based on the schedule. The initial phase was more intense. So the first 3 vaccines are given within a 20-day period. And then gradually that interval increases eventually every 6 months thereafter. So what were our endpoints? So the primary endpoint was defined as overall survival in newly diagnosed patients with GBM. So we had 232 patients in the treatment arm versus over 1,300 external controls. And the secondary endpoint was looking at the overall survival in recurrent GBM patients. And in this cohort, we had 64 patients in the treatment arm versus 640 external controls. So let me show you the results for the newly diagnosed GBM first. So if you look at the median overall survival, a highly significant 3-month survival advantage or so from 19.3 in the treatment arm versus 16.5. So the same ballpark figure of advantage when you look at the temozolomide that was introduced based on Stubb's seminal work. Now, if you look at the patients who had MGMT methylated variants of a tumor, then that advantage is even greater. So here you have 9 months advantage, 21.3 versus 30.2. And we see that with chemotherapy as well, the patients who have MGMT methylated tumor seem to respond better to these kind of treatments. And very interestingly, we have this survival tail. So the 5-year survival is over twice in patients who had the treatment versus those who did not or in the control group. And particularly interesting is the survival advantage in those cohort of patients, such as the elderly, who are traditionally considered to be in the worst prognostic group. And I'll show you that data very shortly in more detail. So this is a Kaplan-Meier curve showing the overall survival in patients with newly diagnosed GBM versus control, highly significant p-value, and as I mentioned, around 3 months survival advantage in this cohort of patients. Now, this is the slide that elaborates on that long-term survival. So as you can see, as we move from 36 months to 4 years to 5 years, eventually, that difference between the treatment arm versus controls becomes greater. And at 5 years, more than twice patients are alive in the treatment versus the control groups. So here we have separated the patient in terms of age, and you can see on this side, patients over the age of 65, and on this side under. And although the p-value is highly significant in both cohorts, you can see the relative gain of survival advantage is greater in those patients who are older than 65. I thought about this a great deal, and I suspect the reason is because the side effect profile of this vaccine. As you know, a problem in the elderly is the ability to cope with the side effects of radiation and chemotherapy. And I guess in patients who are having these vaccines, that side effect profile is arguably even much kinder. I mean, in our cohort of patients, in well over 1,000, several thousand injections, we really only had 5 significant side effects, what we call SAEs, so significant side effects in that cohort of patients. And I guess this, the fact that the treatment has got a better, much better tolerated side effect profile is the reason why we see this differential gain in older patient cohorts. And I've already mentioned to you that a patient with MGMT methylated variant of the tumor seem to respond better to this treatment. I can see that on this side of this graph. How about for recurrent GBM patients? So much the same really, although the advantage seems to be even greater. The median overall survival for the recurrent patients, 13.2 months versus 7.8 for the patients in the control group. And again, we see that survival tail. And as we go over the years from 24 months to 30 months, again, that difference becomes greater. But again, more than twice patients alive at 30 months in patients who had the treatment versus the ones in the control group. Again, this Kaplan-Meier curve just puts that information in a graphic format. You can see the 6-month benefit in the overall survival in patients who had the treatment versus the control group. So I only had 10 minutes. So I'm just going to summarize here, but hopefully can discuss a lot more in the discussion section. So this is just really the highlights of this data I've shown you. So really this phase 3 trial is the first trial in 17 years to show any systemic treatment conferring significant extension in terms of overall survival in patients with newly diagnosed GBM. In terms of recurrent GBM, really the first treatment of any kind, systemic or otherwise, to show benefit in 27 years. And it's one of the first, if not the first, phase 3 trial to show this long-term survival, which I think is well worth investigating. Why is that a cohort of patients seem to respond so much better to this? And that's really something that we need to look at, and I've got plans for that, hopefully, which we can implement. And of course, which is something which was very interesting to my eyes, was the fact that you're opening a new avenue of therapy for those patients traditionally considered to be in poorer prognostic cohort, such as the elderly patients. And I think that's because of its more favorable side effect profile. I'm going to end here. Very happy to answer any questions you have, and I'm sure there'll be a lot to discuss in the next section. Thank you very much.
Thank you very much, Farouk and Ash. That was really good overview of both types of treatment. I'm going to open the questions with a question to Paul. Should these treatments be available on the NHS?
Yeah, so it's a really good question, a difficult question to answer, because it very much depends on your perspective, doesn't it? And we are, as a group here this evening, a biased population, aren't we, in the sense that we're all very interested in and passionate about the treatment of brain tumours. So I would say if I was a patient or a carer, I'd very much want to have access to these treatments. As a specialist, someone looking after patients with brain tumours, I want the best for my patients with brain tumours. But you do have to have that, take a step back and look at it from a more global NHS funding perspective, don't you? In that there is a pot of money, there is a budget of money allocated to healthcare in this country. I can tell you it's recently been reported that more than 2/3 of providers at the moment are running a deficit budget, which means that most hospitals in this country are spending more money than they already have available on the current healthcare they have. So the thought of them then investing an awful lot more money in treatments that are incredibly expensive and have a relatively limited benefit is quite a difficult concept at the moment. So there has to be someone, because this is not just these 2 treatments for brain tumours, this is thousands of treatments across lots of different conditions that would cost a lot of money. So there has to be a judgment made at some stage, doesn't there, as to how we would responsibly fund new technologies using the money that the taxpayers have generated. And either we'll all be paying a huge amount more in additional tax to fund some of these incredibly expensive novel therapies, all we have to in some sense is ration them in some way. So despite the evidence that they are of benefit, and we've seen some good evidence this evening, we have to make that judgment, don't we? And NICE use thresholds, as many of you will know, in terms of how they might make that judgment, cost per quality, adjusted life year, and so forth. So really difficult decisions, aren't they? And really, you know, for many people, very personal ones, but you can kind of understand the bigger picture piece, which is at the moment, there's simply not enough money to fund all of the novel treatments that are becoming available.
Okay, thank you, Paul. And I think that's bringing us a sort of, it's always nice to hear these new treatments, and it's great to hear new treatments. It sort of brings us down to earth a little bit. I'm going to ask Louise, as a clinical oncologist, one of the issues that we had with the Tumour Treating Fields trial was actually getting the clinical oncologists from other parts of the country to be part of it. So, Louise, what's your view on these treatments? Do you think this is a way forward?
I think when you're training in oncology, one of the first things you learn when you learn about trials is that for every trial that comes to sort of clinical practice and use, there are, you know, scores more that are put through these early phase studies. And I think it's what we want to do is get excited about these trials, and we obviously are, but if we put that into the picture of what we know about how learning about tumours and treatment works, unfortunately we have to run through many different iterations of treatments to finally find something that does work. I think what we know from glioblastoma is that standard chemotherapy is often not very effective. If you think about breast cancer, there are 10 or more different standard chemotherapy drugs that are used, and for glioblastoma that is not the case. We have a very small number of drugs, and so we know that we do need to spread the net wider, and I think that's where these different approaches, the intraoperative radiotherapy, the TTF, the DC-VAX are interesting approaches. But I think that as per what Paul was saying about the funding we have nationally for treating these drugs, I think as oncologists we are cautious to know that we can't offer this for all of our patients because the funding is not there. And obviously we want to say open all the trials in the world and try everything, but we have to be quite selective to try what we think has the best chance. And just the other one thing to say is that I think it's known that trials patients often do better than your average patient because they are inevitably a selected group of patients, and we have to be aware of that when we're thinking about how this information will relay out to our general patient group who have not been on trials.
Okay, thank you. There's a lot of interest in the chat, Ash and Farouk. So Ash, there's questions about if patients haven't had tissue sent, frozen, what tissue do they need to be able to have dendritic cell therapy?
Sure. Hello, everybody. I hope you can hear me okay. So absolutely, it is quite critical to have the tissue fresh frozen. So at the time of surgery, your surgeon needs to be aware that there is a plan to do something with this tissue, because the minute it's put in paraffin, which of course a standard UK management is to put the tissue in paraffin. And that's because it's much easier to store and much cheaper. So it's another cost issue. I mean, to be honest, there is no reason why we shouldn't bank all our tissue fresh frozen. And I discussed it with Paul Grundy in the BNOS. I mean, we should move towards having the facilities, including the -80-degree freezers. I mean, that's all it takes, the -80-degree freezers available in every center. In that case, you can then keep every piece of tissue frozen. And as long as it's frozen immediately at the time of surgery, then that is available for anything, including DC-VAX. But unfortunately, once those cells are killed by putting them or fixing them in formalin, then that opportunity is lost. So if there is tissue available, as long as it's frozen at the time of surgery, then yes, that can be used for DC-VAX. But if it is not, if it's been put in formalin, then unfortunately that opportunity is lost. But I do really think we should campaign towards banking all tumor tissue fresh frozen.
Okay, and there's another question about when you think the scientific manuscript will be published. Has it been submitted as yet?
It is in a process. I can't tell you much more than that because obviously, as we all know, publications are at the mercy of peer reviewers. So the process obviously has been started. We did the presentation, and natural follow through from that is to go towards publication, but I can't update you at the moment except to say that we are in the process and we all keep our fingers crossed that that data should be available in a published peer-reviewed format before long.
Thank you. And Farouk, we know DC-VAX needs fresh frozen tissue. What about Tumour Treating Fields? Any prerequisites?
No, not really at all. It's once patients have had surgery, then they can go ahead with TTF. And that's one of the things the TRIDENT trial is going to be looking at, to seeing whether it is better to give it before chemoradiotherapy or after chemoradiotherapy. Provided patients have had surgery, they are well, and they basically have to shave the scalp to allow the electrodes to be applied to the scalp, to the shaved scalp. No other prerequisite, you don't need any tissue.
Okay, thank you.
And I just wonder whether I could just, I see there's lots of comments about the cost, and obviously Paul quite rightly talked about the issues of the cost. I don't know if I can just have 30 seconds to say something about that. Is that okay? I presume, yeah. I mean, we have to also bear in mind that the cost always comes down with the volume of the usage of any product. So part of the reason why both TTF and BCVAX are expensive at the moment is because the use is very limited. But once that becomes much more standard, hopefully, and a lot more patients are using it, that is bound to drive down costs. So we also need to think about not just what it is now, but what it could become once the usage increases significantly. It's like anything, production, the volume of the production determines how much cost eventually going to be involved. So I think we should have a lot more longer term view of the cost, not just snapshot of what it is now, but what it could be once the volume increases as well.
Thank you. I think there's quite a lot in the chat about frozen tissue, and I know you've answered that, Jill, but it might be worth just asking you to come back into, haven't been on the panel, but you brought us our first talk. How do we make collecting frozen tissue a national thing? How do we get it so that everyone collects frozen tissue, so that, be it dendritic cell therapy or whatever the treatment is, people have those options?
Yeah, I think if there's one thing pathologists are very good at, it is it's optimizing tissue. It's getting the diagnosis we need first and foremost to allow treatment to occur, and then it's doing what we need to get the best treatment for the patient. And we have been increasingly aware of the need to freeze tissue. Certainly anyone enrolled in a trial, that was, for years now we've been doing that, where we've been taking tissue and separating out into the many different storage for modalities it needs. I know I specifically asked about Nottingham because I know this is where Rachel's father has been treated. Generally, we do get things set down from theatre, what we call fresh, so not placed in formalin, and at that point we decide how best to use the tissue. I think as we do more and more molecular testing, it will be much more common that we are taking frozen on every single sample where there is enough scent. And by enough, we're talking sometimes core biopsies taken of, say, up to 5 millimeters. We can still separate that out and still get tissue for frozen in those cases.
Thank you. Paul?
Yeah, and just to say, I think this is a really important topic, and as Ash said, it came up at the recent BNOS meeting, and we've just put a call out actually to try and get together a group of experts to do a bit of work on exactly this, because I think we want to get to the point where everyone is routinely collecting not only their paraffin embedded tissue, but fresh frozen tissue at the same time. It's not just TCVAX, as Ash said, it's other reasons that patients may want to use this tissue. We've got into the habit now with whole genome sequencing and other things of collecting more than one sample to be processed in more than one way. And it's too late when you've not done it and a patient asks you a few months down the line, if you've got that piece of frozen tissue, it's too late. So I think we need to make this ubiquitous. So I think there's a piece of work for us to do. We're going to get this going. Tessa Jal are interested in it and pushing this forward at the same time. We're going to work together, hopefully, on coming up with a policy. I'd very much like to think we get to the point where we write a sort of policy expectation across the country that everyone should be doing this routinely. So work in progress, really important thing.
Thank you. Jill?
Just wanted to sort of lead on from that a little bit around how, as healthcare professionals, sort of being open to conversations with our patients and making them feel really comfortable about asking those questions before they go in from a surgical point of view. As a nurse who supports patients through their oncology treatment, I often have this conversation with my patients, and the disappointment and how disheartened they feel when we have to say, well, actually, I'm really sorry, we've not stored it that way. the question that I get quite often is, but why did we not have the discussion? It might not be available on the NHS, but we could have fundraised, or we could have, you know, we could have afforded that, and that's fine. And I guess now what's quite, I think, exciting within the community is that we are hopefully showing that we do want to have these conversations and we are open to them, and people should feel comfortable asking and talking about possibly, you know, treatments that aren't necessarily you know, funded by the NHS, or something that we would routinely discuss. I hope that patients are feeling a bit more comfortable to ask about things now.
Thank you. Ash?
I mean, as a simple neurosurgeon who's not a pathologist, I mean, is there any reason to actually put tissue in formalin at all? Why don't we just phase out the formalin side of things? Isn't that just for storage purposes, but it's easier to store? And if so, there's only one way of banking, and that will be always fresh frozen. I mean, why do we put tissue in formalin? I mean, there may be a good answer for that, Jill. I don't know. I'm a neurosurgeon. But what is the point of putting in formalin? Why don't we just freeze everything?
Jill, is there a good answer for formalin rather than freezing everything?
I mean, this is formalin fixation, paraffin embedding is the process by which we get the most beautiful, pristine sections in order to use the optimized immunohistochemistry antibodies on. It is how everything is set up in the tumor world. We do work on frozen tissue in where we need to do enzyme work, but not in a cancer setting. For now, I don't, you know, this is the way histology has been done for centuries, probably approaching now. And as a result, I don't think we're going to see any move away from paraffin and formalin. But what we need to get better at is separating out the samples.
I mean, what would be really great is to change the paradigm where us as surgeons just send you fresh tissue, and then you take some of it for formalin and do what you need to do for histology, and the rest is stored, rather than the other way around where we put in the formalin, because that's what we do, and then you don't get anything. So why don't we just change the paradigm, think outside the box, move from the centuries ago and do it new way? We send you guys frozen, fresh tissue, and then you can put some in the formalin as you wish to do it, the pathology, and the rest can be used. I think I'm just trying to be very sort of devil's advocate and change the paradigm and move from what we've done for centuries into something we should be doing 21st century.
Thank you. Michael, did you have a comment?
No, I was going to make the same statement as Professor Ashkan.
And before we move on from that, Helen, are you still on the call?
Very much so.
Oh, there you are.
Really engaged.
What about the role of charities in trying to push this forward?
Okay, so where do I begin? I'm a great advocate of tissues being frozen. I had one patient who asked his neurosurgeon if he could have his tissue frozen, and the neurosurgeon said, well, if that's what you want, I'll give it to you. You can put it in your freezer at home. I mean, I do think patients have a role to play in driving this agenda as well, because it's an important discourse to have. I started a group 14 months ago with 6 patients I knew had glioblastoma. They were researching outside this protocol to see what alternative, not snake oil, but adaptive innovative treatments were out there. I didn't want individually them to be spending their time, which could have been time, spent creating memories with their families or doing things that make their hearts sing. They were duplicating. So we created the GBM Knowledge Share, which is a hub now. I think, we are the mortar between the clinical community and the patients. And this group is now nearly 80 patients. I think everybody has a responsibility not to gatekeep information. I think it's up to the patients to be supported to make the decisions that are right for them in their context, because everybody has their own appetite for risk, their own values and their own context. And it's not for any of us to say what you should do. It's not within our gift. But I do think we should be supporting patients and their families to find the information and then to help them make the decision that's right for them.
Thank you. Louise, I've got a question in the chat I'm going to direct to you if that's okay. The question is aside from NHS treatments, are there any recommendations, and these are obviously quite different things, for the care oncology protocol or Avastin, which is offered to many US patients? Would you like to take one of those topics and comment?
Yeah, so I work in Romford near, on the outskirts of London. So it's a care oncology clinic. I don't know if there are other ones elsewhere in the country, but certainly there is one in the centre of London. And I think that patient chats offline away from hospitals go through phases of this being mentioned quite a lot, and so many of my patients have gone to care oncology. And I think, I'm certainly, NICE guidance is us as medical professionals should talk to our patients about this, because we know there are not very good treatments, ratified treatments. So of course people are exploring other things. But I think the NICE guidance would say that we should not be encouraging necessarily patients to do these things, because there is concern potentially about side effects from some of the treatments, and also about paying money for something that is not necessarily guaranteed or even shown to give a better prognostic outcome. On the other hand, of course, as I said, there are, the standard treatments are not the golden bullet, and patients want to try other things, and we'll have that frank discussion. And many of my patients have used the care oncology treatment. Some have carried on for a long time and have found it very supportive, and some patients have stopped because of side effects or because they felt it was not helping them. So I think it's very individual, and some patients will go for these things and some won't. I certainly wouldn't encourage people to, but that's my view. And regarding Avastin, there was the trial that ran in the UK about 10 years ago that did not show a great advantage with Avastin, and so it has not been put through NICE to be a beneficial treatment. So it's not something we run in the UK.
Thank you very much. Paul?
I think it's probably sort of two dilemmas here, aren't there? There are treatments, as we just heard, some of which have no evidence base, or they have been tested and the evidence shows that they're not effective. And then there are other treatments that we have just heard about this evening that we do know from the evidence base probably are effective, but at the moment unaffordable. That poses probably different dilemmas, doesn't it? So one of the questions we were asked as a society was, and I explained at the outset, I'm a fan of shared decision making. That means discussing with your patients all reasonable competing options. Now, should that then include options that have an evidence base, so they're a reasonable option, but that aren't funded on the NHS? And one of the issues then is that those treatments are only accessible by a very small minority of often very wealthy individuals, and there are issues around health inequality there. So there's a bit of a moral and ethical dilemma here. I think I feel in much more comfortable ground where we know something's been tried and tested and it has little evidence, and at least we can explain that and have that conversation. The things that do have evidence, we need to discuss them. Do we discuss them with every single patient who comes to see us, knowing that most of those won't be able to access them? That's a bit more of a dilemma for me.
Thank you. Michael?
Yeah, I was just going to say, well, slightly to follow on from what Paul says, I think in the shared care decision making, you have to discuss what is available within your healthcare system. I think that's entirely reasonable. There are other treatments that people are being offered in different healthcare systems in Europe and America that I don't feel we need to mention because we don't have access to them and they're not available. Just to sort of counter what Louise Dully said, I mean, we get asked as well as surgeons, what, should I take CBD or should I take metformin, all these other treatments? I take a slightly different approach, which is to say, if you're going to take some medication or treatment that's not being prescribed or not being advised by your clinical team, as long as you inform your clinical team about them, that's important, number one. And number two, as long as you're not paying through the nose or being financially worse off by taking these treatments or paying an absolute fortune, I think that's also reasonable to do. But I think you do have a duty to tell your clinical team what you're taking, because if some of them cause side effects, they may attribute those to the conventional treatments that you're having and may stop them unnecessarily.
Thank you. Ash?
Just want to add a number 3 to those very wise 2 points that Mark Jenkinson just said. Number 3 is to ensure if you're taking experimental therapy, it's not in lieu of your standard treatment. It's an add-on, not instead of. Because standard treatment is there because it's standard treatment with good evidence base. So no experimental treatment should ever be taken instead of a standard treatment, but alongside. I think that's critical. And I've said that all the way along every time I've done an experimental study.
Thank you. Okay, well, we're reaching the end of the evening. I'm going to ask Kaj, any last comments? That I'm going to leave the last word to you, if you like, before I sort of wrap up. Anything you want to say about the treatment, any of the talks we've had this evening?
Oh God, no pressure. No, it has been very enlightening and also very promising. When I do think about brain tumours, you know, I do tend to think of sort of like this dark hole that people are going to face an inevitable end, which is their death. But seeing all of these treatments and you know, amazing solutions out there, which will hopefully just continue to grow and develop, is really promising to see. And I would say to anyone out there that is currently suffering from a brain tumour or don't know what to do, a lot of it comes from within yourself and your own willpower as well, and to just be, you know, as brave as you can. And just there is a lot of resource, a lot of support out there with the Brain Tumour charity as well. So please don't feel like you have to go through it alone.
Thank you very much. And I'm sorry to spring that on you at the last minute, but nice answer. So I'd like to thank everybody. I'd like to thank our speakers for doing their presentations and joining us tonight. I'd like to thank our expert panel. And most of all, I'd like to also thank Jen and the Brain Tumour Charity who helped run this thing. But most of all, I'd like to thank you, the people who joined us this evening. We will be asking for feedback to hear whether we should be doing this again, how we can do it better, and what your views on it were. There will be a recording of this available, and there'll be links to it when you get your feedback once we've finalized that. So thank you very much, everybody. Hope you've enjoyed it. I certainly have. I've certainly learned a lot. I hope everyone else has. So good night.